Hello and welcome to the Blocks for Foot and Ankle Surgery Block Pack Workshop presentation for the American Society of Regional Anesthesia and Pain Medicine meeting scheduled for April 1st, 2022 in Las Vegas, Nevada. My name is Adam Neeson and I'm an assistant professor of anesthesiology and perioperative medicine at Mayo Clinic in Rochester, Minnesota. The rest of the team you see here will be ready to help show you how to do ultrasound guided blocks for foot and ankle procedures. We're excited to have you and look forward to a great workshop. This will be our basic workshop structure. We will have a two-station format of 90 minutes total. The 15 minutes of introduction and housekeeping is largely being done with this video, so that means additional time will be available for scanning. We will still maintain 15 minutes at least at the end for review and discussion. Participants will rotate once during the workshop. There will be two 30-minute stations. Station 1 will involve popliteal and adductor canal / saphenous blocks, and Station 2 will contain ankle block. The goals for this workshop are to improve understanding and confidence in blocks for foot and ankle surgery. Ask questions and have fun. We're here to help you learn. We want to review foot and ankle neuroanatomy, demonstrate relevant sonoanatomy in real time, and describe tips and tricks to optimize imaging to enhance your chance of success the first time. For the best chance of success, the regional anesthesiologist must understand foot and ankle innervation. The foot and ankle is innervated by two main nerves. The sciatic nerve, which supplies motor and sensory below the knee except for the medial side of the leg. The sciatic itself divides into tibial and common peroneal components above the knee. These components reside in a common paraneural sheath prior to their dividing. The saphenous nerve, which is a branch of the femoral nerve, is sensory only and provides coverage to the medial leg. In terms of dermatomes, as you can see by this image, L4 through S2 provides coverage for the lower leg. As stated previously, the majority of the leg and foot are innervated by the sciatic nerve, demonstrated in this image with the area filled in red. The remaining medial part of the leg, which is shown in blue, is innervated by the terminal branch of the femoral nerve, the saphenous nerve. In this cross-sectional view, you can see that the tibial nerve and common peroneal nerve lie between the biceps femoris muscle and the semitendinosus muscle and tendon. The nerves are also in close proximity to the popliteal artery and vein. Applying the probe to the posterolateral aspect of the thigh shows the relevant neural structures and the vascular structures, and your needle will come in from a lateral to medial angle. In this side-by-side picture, you can see the common peroneal and tibial nerves directly overlying the popliteal artery, as well as lying between the semimembranosus muscle and biceps femoris muscle, similar to what was seen in the previous slide. This video will demonstrate how the tibial and common peroneal nerve interact with each other as you scan up and down the leg. As one scans more proximally, the nerves come together and create a single nerve structure, the sciatic nerve. Unfortunately, as you go more proximal, the nerve does get a little bit deeper, so it gets a little bit harder to see. As you come more distal, the nerves begin to spread apart, with the common peroneal taking a track that is more superficial and further lateral compared to the tibial nerve. We say that it's high and outside, kind of like a bad pitch in a baseball game. Let's watch the video. You can see the tibial on the right-hand side of the screen, common peroneal on the left-hand side. Let's restart the video. As we get even more distal, they get further apart. You see an excellent popliteal artery, again, tibial nerve, common peroneal nerve. Let's start it again. Here we're coming proximal again. And you you can see that they have become essentially one nerve structure. They do run in that common paraneural sheath, however, so you need to get your local anesthetic inside that sheath to get a good block. Here are some pro tips to improve your chance of success with a popliteal block. As we discussed in the video, the sciatic nerve moves from deep to more superficial as it approaches the knee, from a more proximal location to distal. Tilting the probe so the angle is toward the toes can create a more perpendicular angle on the nerve and make it look brighter on the screen. Better visualization leads to an easier block. If you do the block where the tibial and common peroneal are in that common sheath, entering into the sheath by taking care not to become intraneural with your needle position provides a more reliable block. Lastly, the block does not necessarily need to be done where the nerves are together. You block it where you see it the best, which is a common theme for regional anesthesia. I look at it similar to a brachial plexus block. You can block that anywhere along the plexus and you can still get all the nerves. In order to achieve anesthesia of the entire leg, we need to also block the saphenous nerve along its course. The easiest way to do this is with an adductor canal block, outlined here in red. The adductor canal is bordered by a number of muscles. The most important are the vastus medialis, the sartorius, and the adductor magnus. In the adductor canal lies the superficial femoral artery and vein and the saphenous nerve. In this video, we will demonstrate the process for identifying the adductor canal for performing adductor canal blockade. You start by visualizing the femur and then scanning more medially. As we scan medially, the sartorius muscle is identified as a nice sharp pointy muscle over the superficial femoral artery. The saphenous nerve lives just lateral to the artery. In order to get into the formal adductor canal, we scan more proximally on the leg until the artery resides underneath the thick part of the belly of the sartorius muscle. This is the optimal place to perform an adductor canal block. You can see next to the pulsating artery a large vein. Oftentimes there will be another vein on the opposite side of the artery as well, which you have to watch out for when placing your needle. Why don't we just do a saphenous block at the knee? The blind technique, infiltration at the level of the tibial plateau, is not consistently successful. Using an ultrasound and identifying the associated nerve and vein is more successful. However, identifying those structures can be challenging, particularly if the patient's leg is edematous. Overall, blockade in the adductor canal is familiar given its use with knee surgery and more reliable. Here are some pro tips to improve your success with adductor canal blockade. The artery should lie under the thick middle part of the sartorius muscle for best results. In patients where the adductor canal is deeper, tilting or towing in the probe can help needle visualization. It is important to remember that occasionally the local anesthetic may spread to the sciatic nerve if you're doing an isolated adductor canal block. Watch out for foot drop after this block. It does happen. Tourniquet placement on the thigh complicates the use of a combined popliteal and adductor canal block as a primary anesthetic. Most patients will require a general anesthetic or a spinal if a tourniquet on the thigh is going to be used. Let's move on to the ankle block. It's important to review the location and correlation of all 5 nerves around the ankle, including the tibial nerve or posterior tibial nerve, the saphenous nerve, the deep peroneal nerve, the superficial peroneal nerve, and the sural nerve. This illustration demonstrates the coverage patterns for each of the nerves. As you can see, the tibial nerve covers a very large portion of the sole of the foot and the heel. The lateral foot and small toe is covered by the sural nerve. In between the first two toes is covered by the deep peroneal nerve. The top of the foot is covered by the superficial peroneal nerve, and the medial side of the ankle and foot is covered by the saphenous nerve. Like many other nerves, the posterior tibial nerve lies in close proximity to a vascular structure. In this case, it's the posterior tibial artery. These structures lie deep to the flexor retinaculum. It is important to penetrate the flexor retinaculum to get the local anesthetic in close proximity to the nerve. In addition, the posterior tibial nerve is the largest nerve involved in an ankle block. This means that it has the longest setup time for adequate anesthesia. It has the largest coverage area, and in general, it's the most important nerve to block for the majority of foot procedures. When scanning for the posterior tibial nerve, the probe should be applied to the posteromedial aspect of the ankle near the medial malleolus. You will see a cross-section of the bone, the artery, and the nerve. We will see this in the next video. In this image, we can see the tibia as the bony white structure on the left-hand side of the screen, the posterior tibial artery, and the posterior tibial nerve. Let's start the video to see what this looks like as we scan up and down the leg. You can see the artery pulsating away on the top part of the screen, and the nerve stays in close relationship to it as we scan more proximally on the leg. The three anterior nerves of the ankle block are the saphenous nerve, the deep peroneal nerve, and the superficial peroneal nerve. They lie in fairly close proximity to each other, so much so that when doing a traditional field block, all three can be blocked through the same needle insertion site. Unfortunately, this usually is not possible when using ultrasound. In order to locate and block the deep peroneal nerve, the ultrasound probe is applied to the anterior side of the foot. The main landmark that we look for is the dorsalis pedis artery. The deep peroneal nerve is usually visible as a very small nerve very close to the artery. Both the nerve and artery lie directly above the tibia. In this video, we will see the pulsating artery in the middle of the screen and a vein directly to its left. Directly to the left of that vein, in very close proximity, is one branch of the deep peroneal nerve. It is located right here. This patient has a divided deep peroneal nerve and has another branch that you will see show up in this tissue plane to the right of the artery, and will go up and over the artery as we scan back and forth. Importantly, if you get perivascular spread of your local anesthetic, you will get both branches. And even if you can't see an accessory branch, the vast majority of the time you will get coverage as long as you get local anesthetic spread in that plane. Our next nerve to discuss is the saphenous nerve. It lies directly adjacent to the large saphenous vein on the medial side of the foot. Applying the probe directly over the medial malleolus should help you find the vein. In this video, you will see the large saphenous vein directly overlying the medial malleolus, or the tibia. You see the bright white line of the tibia on the screen and the vein right over it. No neural structures are formally visible at this time. This is fairly typical for the saphenous nerve block. We next turn our attention to the superficial peroneal nerve. It lies on the lateral aspect of the foot and has branched into 2 to 3 branches at the level that it is normally blocked with a field block. Applying the ultrasound to the lateral side of the foot, one must scan approximately 10 to 15 centimeters more proximal in order to locate the nerve before the branching has occurred. The superficial peroneal nerve, as its name implies, is extremely superficial. It lies in the tissue plane directly above the peroneus brevis muscle and the extensor digitorum longus. The peroneus brevis muscle is on the left side of the screen here, and the extensor digitorum longus is on the right side. There is a tissue plane between the two muscles that points directly to the nerve. Occasionally, the fibula is also somewhat pointed and points directly to the nerve. The nerve sits in a small hammock-like structure at the intersection of the two muscles. Lastly, the sural nerve is located at the posterolateral aspect of the foot, posterior to the fibula. It is in close proximity to the small saphenous vein. Applying the probe to the posterolateral aspect of the foot will give you a good view of the small saphenous vein. Attention should be paid to gentle pressure on the probe so as not to collapse the vein. This video will show the small saphenous vein and associated sural nerve. The small saphenous vein is extremely superficial with the nerve directly to its right. Injection in this tissue plane to get perivascular spread will result in reliable coverage of the sural nerve. Some things to remember when performing ankle blockade are that tendons can occasionally masquerade as the posterior tibial nerve. In order to not be fooled, if you have multiple structures that look like a nerve when scanning, direct the probe more proximally. As the tendons turn into muscle bellies, the nerve stays the same, so you can be sure which structure is the nerve and which ones are tendons. Light pressure is necessary for the saphenous and sural nerve injections. If you press too hard with your ultrasound probe, the vein goes away and it gets very difficult to know where to put your local anesthetic. On a related note, perivascular injection is effective if the nerve is not fully visible. This is true for your deep peroneal, saphenous, and sural nerves. As discussed in the superficial peroneal nerve block, the fibula and the tissue plane between the extensor digitorum longus and peroneus brevis muscles will usually point to the nerve. It almost takes on a mini adductor canal or hammock appearance. We look forward to your questions and answers during the workshop. We're excited to have you. Thank you for your time, and we'll see you in Vegas.